medicine. Okay, so let's start. The first topic that we are going to discuss is very, very important: screening of diseases. A very important topic. You can expect minimum 3 to 4 questions every year. And this is a topic which is very close to our clinical practice, because every day sitting in OP, you prescribe a lot of screening and diagnostic tests to your patients, right? Starting from FBS, RBS up till CT, MRI, you prescribe a lot of screening and diagnostic tests to your patients. So my question is, when you advise your patient to do one particular screening test, what is your intention at the back of your mind? Your intention is that this test should correctly pick all those who have the disease, and this test should be able to correctly rule out all those who do not have the disease, right? And how good is your screening test in performing its job is measured using certain parameters like sensitivity, specificity, positive predictive value, and negative predictive value. I know you're already familiar with these terms, and even the whole world is now familiar with these terms in terms of COVID testing. Even the common man is saying nowadays that, okay, don't do antigen for COVID detection. Sensitivity is less. Go for RT-PCR because that has got more sensitivity. So everybody is talking about these terms now. Now let's see what are these and how to calculate them. Using a very simple example, Mando test. It's a simple screening tool for TB. Okay. Imagine that I have 100 TB patients with me. Okay. And I have 100 normal people. Normal in the sense they don't have TB. Okay. So I have diagnosed these 100 to be having TB using a gold standard test, say NAT, nucleic acid amplification test. And I have diagnosed these 100 to be not having TB by a gold standard test. And I am now going to see how good is Mando in doing its job as a screening tool. Are you with me? So, I have applied Mando to the first 100 patients with TB. My question is, will all of them correctly give me positive Mando? What do you think? They all have TB, but will all of them correctly give me positive Mando? No, right? Instead of intradermal, if I'm pricking subcutaneously, it would be negative. If I'm not taking potent drug, it will be negative. If one of the patient is immunocompromised, again, it will be negative. So, due to various reasons, a few number of TB patients can give me negative Mando, right? Now, I'm going to apply Mando to these 100 normal people. Will all of them correctly give me negative Mando? Again, due to various reasons, as you can guess, a few number of normal people can give me positive Mando result. Okay, are you with me? I'm going step by step. Just imagine that out of these 100 TB patients, when I applied Mando, say 80 correctly gave me positive Mando result. And out of this 100 normal people, say 90 correctly gave me negative Mando result. Okay, now I'm going to depict what I said now in the form of a 2 into 2 table. And this is how a 2 into 2 table or 2 by 2 table looks like, because it has got 2 columns and 2 rows, horizontal rows and vertical column. One more thing I want to tell you. See, for your exam, the question will be always in the form of a statement. Okay, they'll tell you how many are diseased, how many are not diseased, and how many are test positives and test negatives. And the first thing that you have to construct is a 2 into 2 table like this. And after that, you have to correctly enter all the values inside these cells. If you don't do it correctly, your answer will be wrong. Okay, so the confusion may be where to enter the disease status and test status. It's very simple. I can give you a small tip. Remember, CD. What is C? Column. Okay, C is column, D is disease. That means along the column, you always enter the disease status. Okay, and along the row, you enter the test status. Same holds true when you're calculating odds ratio and relative risk. Okay, always CD. So keep that in your mind. Okay, now as per our example, there were 100, here the disease is TB, right? TB positive, TB negative, and test is Mando test. Okay, so I have 100 TB patients and 100 without TB. When I applied Mando, I said 80 correctly gave me positive Mando and 90 correctly gave me negative Mando. Okay. Now, what can I write here? 100 minus 80? 20. And what can I write here? 100 minus 90? 10. This is how you construct a 2 to 2 table. So simple. Okay. Now, next points. These are your true positives. These are your true positives. That is also an MCQ. These are your true negatives. Right? Now my question is, which was a question 2 years back, an MCQ 2 years back, what do you call these 10 as? See, these 10, they don't have disease, they don't have TB, but Mando called them as having TB. Okay, or Mando branded them as having TB. So what do you call them as? See, the cells are always named according to the screening test result. Here the screening test called them as having the disease. So they'll be branded as positives only, but they don't have the disease. So it is false positives. And what about these 20? Mando said they don't have the disease. So they'll be branded as negatives only, but they do have the disease. So it is false negative. This is also a very, very important MCQ. Okay. The question which came 2 years back was, as per the gold standard test, Mr. X has disease. But the screening said he don't have the disease. So what do you call him as? He'll be false negative, right? Okay, so this question you can expect, and for that this concept is very, very important. Okay, now I'll tell you what is sensitivity, specificity, positive predictive value and negative predictive value. Very simple. Let's start with the first one, sensitivity. What is sensitivity? Very, very important. I don't want you to mug up. Just listen. Sensitivity means, listen carefully, ability of your screening test to detect all those who have the disease from the diseased population is sensitivity. So while calculating sensitivity, in the denominator, you put all those who have the disease. Among them, how many were correctly picked to be having the disease by your test is sensitivity, which is 80 here, right? Then what would be specificity? Specificity means ability of your screening test to detect all those who do not have the disease from the non-diseased population. So, while calculating specificity, in the denominator, you put all those who do not have the disease. Okay, among them, how many were correctly picked to be not having the disease by your screening test is specificity, which is 90. Okay, so here the answer is 80% and here it is 90%. Okay. So, sensitivity 80% means this test can only detect 80% of original deceased. 90% specificity means this test can detect only 90% of non-deceased. Are you with me? And one more property we discussed, which is predictive value. And as you know, we have two types of predictive value, positive predictive value and negative predictive value. Now, let's see what is positive predictive value or PPV. Do you want me to write it? Positive predictive value. Okay. Now what is it? Nothing to mug up. As the name indicates, positive predictive value means out of those who were predicted to be positive by the test. Okay. Which includes true positives as well as false positives. This is the total number of positives. How many are total positives? 80 plus 10, that is 90. 20 plus 90 are total negatives. These are total test positives. These are total test negatives, right? Now, what is positive predictive value? As I told you, out of those who were predicted to be positive by the test, how many are actual positives? So, while calculating positive predictive value, in the denominator, you put all those who were predicted to be positive by the test, which is 90. Okay, 90 were said to be having the disease by the test, which actually includes true positives as well as false positives, right? Out of that, how many are actually having the disease, which is 80. Okay, and what would be negative predictive value? Now it's very simple. What is negative predictive value? Out of those who were predicted to be negative by the test, how many are actually not having the disease? So while calculating negative predictive value, in the denominator, you put all those who were predicted to be negative by the test, which is 110 divided by, upon that you write who are actually negatives, who do not have the disease, which is 90, right? Look at this. This is your negative predictive value. So this will be approximately 89% and this is approximately 82%. Are you with me? This is sensitivity, specificity, positive predictive value and negative predictive value. Okay, positive predictive value means out of those who are positive, how many are actually having disease. Negative means out of those who were tested to be negative by the test, how many are actually do not having the disease. Okay, all these are MCQs. I hope you are with me. Okay, moving on to few more MCQs from this. Instead of this, suppose I am putting A, B, C, D. Can you see? A, B, C, D. This is your A, B, C, D. Then what will be sensitivity? Next MCQ. Sensitivity would be A divided by A plus C, right? In terms of true positives, false positive, true negatives and false negatives, it would be true positives divided by true positives plus false negatives, right? Now what about specificity? That would be D divided by B plus D. In terms of the next values, it would be true negatives divided by true negatives plus false positives. Now what about positive predictive value? True positives divided by true positives plus false positives. In terms of ABCD, that would be how much? A divided by A plus B. And negative predictive value would be true negatives divided by total test negatives. That means true negatives plus false negatives. And in terms of ABCD, that would be D divided by C plus D. Now, just have a look at this. Each of this is an MCQ. See, in terms of ABC, that is a very important MCQ. This is an MCQ. See, all these are MCQs. Very, very important. These are simple, but every year you can expect MCQs from this. Okay. So, have a look at all these MCQs once again. This page is full of MCQs. Now, going to the next part of the same topic, problem-based question. This is how you're going to get the questions. Okay, let's not waste our time on this. We'll be quickly going through one or two questions. A drug company is developing a new pregnancy test kit for use on an OP basis. The company used pregnancy test on 100 women who are known to be pregnant. Out of the 100 women, 99 showed positive test. Upon using the same test on 100 non-pregnant women, 90 showed negative result. What is the specificity of the test? Here, the disease is, condition is pregnancy. So you have 100 pregnant women, 100 non-pregnant women, and the test results are also given based on a new pregnancy test kit. Now, if given time, won't you be able to do it? Okay, you can do it, right? So let's quickly go through the answer. See, this much is already given in the question, right? Out of, you have 100 pregnant women, 100 non-pregnant women. The new pregnancy test kit gave 99 positive out of pregnancy and 90 negatives out of non-pregnant women. Now, can't you fill the rest? Yes. And sensitivity, specificity, positive predictive value and negative predictive value, everything you can find from this. Is it not? So, the specificity would be 90 divided by 100, which is 90%. And not just specificity. Let them ask anything, you will correctly find the answer, right? Okay, moving on to the next. A physical examination was used to screen for breast cancer in 2,500 women with biopsy-proven adenocarcinoma of breast and 5,000 age and race match control women. The result of a physical examination were positive in 1,000 cases and 800 control women. The sensitivity, positive predictive value of the physical examination are respectively. By the way, which is the disease here? Adenocarcinoma of breast. Which is the screening test here? Physical examination. Okay. And it's clearly said that out of 2,500 CA patients, when they did a physical examination, 1,000 were found to be positive. And out of 5,000 patients without CA breast, 800 gave positive result. This means they have already given in the question. Now, can't you do the rest? Yes. Okay. And sensitivity 1000 divided by 2500, specificity 4500 divided by 5000, positive predictive value 1000 divided by 1800, and negative predictive value 4200 divided by 5700. Out of this, 2 are the questions in this particular MCQ, which is 40% and 55%. Okay, I know I'm going quick because we don't have that much time. Already you are familiar with the concept and you know how to do it. Okay, next, let's talk about 3 more terms which are very, very important for your exam and which were previous MCQs. Validity of a test. What do you mean by validity? Validity means how good is this particular test in doing its job, or this is a definition which itself is an MCQ. Ability of a screening test to measure what it is supposed to measure. For example, just imagine that my blood pressure is say 120/80 and there is a sphygmo manometer. If that can correctly detect my BP as 120/80, then only I can call it as valid. Is it clear? That means ability to detect the truth. That is the next MCQ. Ability of a test to detect the truth. That is the next MCQ. Okay. Third MCQ. This is also known as accuracy. Also known as accuracy. Okay. Fourth MCQ. Which are the components included in validity? Validity means ability to detect the truth, right? Now, how many true values are there? You have true positives as well as true negatives. Now, what is true positive? Sensitivity. True negative? Specificity. So, which are the components included in validity? Next question. It is sensitivity and specificity. Sensitivity and specificity are the components included in validity. Each of this is an MCQ. Hope you are with me. Okay. Moving on to the next. Reliability of a test. Now, what is reliability? See, that is something that we usually use in our, conversation. Is that person reliable? That means, will he always remain like this, or is there a chance that he may change his words after some time? Okay, so reliability means the same all the time. Okay, and the definition is yielding same reading or value when repeated under same condition. Okay, this is also an MCQ. If that BP apparatus is consistently giving 120/80, 120/80, 120/80 when tested on me, okay, then I can say that it is reliable. Okay, every 5 minutes, if it keeps on giving the same value, then it is reliable. Okay, next MCQ. It is also known as precision or consistency or reproducibility. These are also MCQs. Okay, and the last term that I said is yield of a test. Okay, yield, you can guess. There is nothing to, learn. Yield is again another term that we normally use. Yield means what is the outcome? That means amount of previously unrecognized diseases that is diagnosed as a result of screening effort. After doing screening, how many new cases which were undiagnosed earlier were picked by this test is yield. Are you with me? Okay. See, this was a previous MCQ. Validity of a test is based upon all except, what is it? Sensitivity is there, specificity is there, accuracy is another term, whereas precision is not validity but reliability. So the answer is precision. Reliability of a test means this is a frequently asked MCQ. Okay, yielding same result or value when repeated under the same condition. Okay, so just to summarize this particular topic, screening. What all we have learned? Very, very important. Sensitivity. What is sensitivity and how to calculate sensitivity? And those A by A plus C, then that true positives divided by those things are there in your mind, right? Similarly, the same for specificity, positive predictive value, negative predictive value. Sometimes they won't give positive predictive value as such. They will only give PPV. Keep in your mind it is positive predictive value. And 3 more other terms from which we discuss few MCQs, which are validity, reliability, and yield. And also problem-based questions from sensitivity, specificity, PPV, and NPV. Okay, hope you are with me. Next very important chapter that we are going to discuss is epidemiology. It's a huge chapter, guys. Really huge. Now let's see the MCQs from epidemiology. Important ones. By the way, the person who practices epidemiology is an epidemiologist, right? And one of the important jobs of an epidemiologist is to study epidemics or disease outbreaks. Okay, so I have a question. When an epidemiologist, he visits an outbreak affected area or an epidemic affected area, what are the things that he is studying? First, he want to know the number of people who are affected with that disease in that population, or in epidemiological terms, you call it as frequency. That means number of people who are affected with the disease. So you'll get an idea of how big that problem is. Second, you want to know what are the clinical features that are seen with that particular disease in that particular population. Or in epidemiological terms, you call it as distribution. That means how are the clinical features distributed in this particular population. And the third is, what are the risk factors that has led to this disease in that population or this outbreak in that population? Or in epidemiological terms, you call it as determinants. That means those factors which determine the occurrence of disease or the risk factors. Determinants means actually risk factors. Distribution means clinical features. Okay, so what you study in epidemiology is mainly these three, which is your first MCQ. What do you study in epidemiology? You're studying frequency, distribution, and determinants. This is your first MCQ. Okay, moving on to the next. See, out of these three, the most important is frequency. Okay, now in frequency, see, I told you by measuring the number of people affected, you are trying to find out how big that problem is in that population. Okay, so if you want to know how big that problem is, what are the things that you want to count? You want to count in frequency, you want to count the number of people who died with the disease, right? Or in epidemiological terms, you call it as mortality. Everybody is not dying, right? There are some people who become morbid with the disease or morbidity. And third is, you want to know how many people became disabled with the disease or disability. So this is your next MCQ. Under frequency, you are measuring the number of people who died or mortality, morbidity and disability. Are you with me? So this covers your second MCQ. In frequency, you are measuring mortality, morbidity, disability. Okay. Now, let's see how to measure mortality, which is very, very important for your exam. How to measure mortality or death in a population. Okay, before going to this topic, let me tell you the type of questions that you can expect from this. First one, the name of mortality indicators. Okay, name of mortality indicators are important. Then the formula is important, which we will discuss shortly. And problem-based questions. Problem-based questions using this formula. Okay, now let's see the first one. Which are the mortality indicators, or how do you measure mortality or death in the population? See, mortality is measured using 5 indicators, which are, we'll see the names: crude death rate, specific death rate, case fatality rate, proportion mortality rate, and survival rate. These are the 5 mortality indicators. Now let's see the second part. What is a formula? Nothing to mug up. Just use your common sense. It's very simple. Just logical. Crude death rate. As the name indicates, what do you mean by crude? Crude means non-specific. Okay, it only tells you out of total people living in an area, or out of 1,000 people living in an area, how many died. So naturally, what will be the formula? Think total number of deaths divided by media population into 1,000. So that will tell you per 1,000 people living in an area, how many deaths occurred. Okay, media population means middle of the population, the number of people in the middle of the, sorry, not middle of the population, middle of a year, which is July 1st. Okay, that means total number of people in a country in the middle of the year. Okay, now question, by the way, mid-year population is July 1st is also an MCQ. Okay, now as I asked you, why do you say this is crude or not specific? Because this will not give you any specific information like which disease is killing the people or which part is dying because of the disease. Do you think such information is important? Just imagine that crude death rate of India and UK are the same. In UK, more of elderly people are dying, whereas in India, small children are dying. Even though the crude death rate is the same, do you think the health status is comparable? No. So such information is very important, for which this will not help. So we have the next one, as you can guess, specific death rate. As the name indicates, this will specifically tell you which disease is killing the people or which part is dying. So naturally, what will be the formula? Just think. Number of deaths from a specific disease or occurring in a specific age group or sex group divided by median population into 1000. Okay, so simple. Moving on to the next. What is proportional mortality rate? Nothing to mug up. As the name indicates, what do you mean proportion? A small portion out of the whole. That is proportion, right? Mortality is death. So naturally, what would be proportional mortality rate? Out of total deaths, what proportion is contributed by one particular disease alone? So what will be the formula? Number of deaths because of one disease divided by number of deaths due to all causes into 100. So that will tell you what percentage out of total cases is because of one particular disease alone. Okay, so simple. Moving on to the next, case fatality rate. As the name indicates, what do you mean by case? One particular disease. Okay, fatality, death. Then what would be case fatality rate? Number of deaths caused by one particular disease. So how do you know that? Out of total people who got that disease, how many died? Okay, so what is the formula? Total number of deaths due to a particular disease divided by total number of people who got that disease into 100. Okay, so that will tell you out of total people who got that disease, what percentage died. Okay, and there are two very, very frequently asked MCQs from this case fatality rate alone. That is, this case fatality rate is related to the killing power of a disease. That is the first MCQ from this, killing power of a disease. Killing power of a disease is given by case fatality rate. Second MCQ from the same topic is, it is related to virulence of the agent or the disease causing organism, virulence of agent. See, now we know that in the second wave of COVID-19, we say that virulence has increased due to mutation. Why? Because the case fatality rate has increased. Okay, that means out of total people who are getting, more deaths are happening. That is why case fatality rate is very, very important. Okay, it gives you the killing power of the disease as well as it is related to the virulence of the disease causing organism. Okay, very important. And the last is survival rate. It's just the opposite of case fatality rate. Case fatality rate tells you out of total people who got the disease, how many died. Whereas survival rate will tell you out of total people who got the disease, how many survived. Okay, and survival rate we usually calculate for 5 years. So what will be the formula? Total number out of total people who got the disease, how many survived beyond 5 years. So that is the formula. Number of patients who are alive even after 5 years divided by number of cases diagnosed or treated into 100. So that will tell you what percentage survived beyond 5 years. Now, one more MCQ from this. I told you case fatality rate and survival rate are, they are a little bit complementary. Okay, one is the reciprocal of the other. So, another MCQ is survival rate is approximately equal to, I'm not saying exactly, approximately equal to 1 minus case fatality rate. Okay, or the other way around. Case fatality rate is approximately equal to 1 minus survival rate. This only means that if case fatality rate is 40, survival rate would be 60. If case fatality rate is 20, survival rate would be 80. Like that. Is that clear? So all these are MCQs from mortality. Okay. So we have seen the formula, the name of the indicators, and the third that I said is problem-based question. Have you learned this formula? I'm sure you have learned the formula. Now let's see how to apply that in solving problem. One question which is frequently asked question. In a nation country with a population of 6 million people, 60,000 deaths occurred during the year 2005. These included 30,000 deaths from cholera in 10,000 people who were sick with cholera. The cause-specific mortality rate and case fatality rate from cholera in 2019. Sorry, this is also 2019, okay? Both are same year somehow. It's a printing mistake. This is 2019, this is also 2019. So, what is the answer? Just take 30 seconds to think. I don't want you to do it now. Just think whether you know how to apply it. Okay. Now, moving to the discussion part. I know given time you will definitely do it. This much they have already given in the question. Media population is given, total number of cholera cases given, total number of deaths and total number of cholera deaths are given. And the question is to find out cause-specific mortality rate and case fatality rate. Now, can't you do it? Cause-specific mortality rate is number of deaths from cholera divided by media population into 1000, which is 30,000 divided by 60,000, 5 per 1000. Is it not? Yes. And case fatality rate, total number of cholera deaths divided by total number of cholera cases, which is 30%. So the answer is B, 5 by 1000 and 30%. I hope you will do it correctly. Okay, so this sort of questions, even let me tell you, the question that you get will be easier than this. Okay, hope you're with me. Mortality is over. Morbidity is also important. Disability is not that important for your exam. So let's discuss morbidity too. Morbidity. By the way, what do you mean by morbidity? Morbidity means any deviation from normal health is what you call as morbidity. Okay, now let's see how to measure morbidity. There are two indicators using which you measure morbidity, which are one, prevalence. The first question, which are the two morbidity indicators? One is prevalence and second is incidence. Okay. Now, what is prevalence? First MCQ. You can remember like this. Prevalence include total cases or disease, whereas incidence include new cases. That is the first MCQ. Okay. Total cases means that includes new plus old. New plus old. Now, we'll tell you what it is. We'll discuss prevalence first. Prevalence. Prevalence is nothing but is the total number of disease at one point in time. Total cases at one point in time. At one point in time. For example, suppose I want to know the number of hypertensive patients. The number of hypertensive patients in city X or village X. Okay. In village X in June 2021. I want to know the prevalence or the number of hypertensive cases in village X in June 2021. How can I do that? Do a survey, right? You do a survey. Go to that village X. Then in June 2021, you see how many are hypertensives. Then I can calculate total number of hypertensives divided by total population of village X into 1000. So that will tell me per 1000 people in that village how many are hypertensives. This is prevalence. Okay, this is prevalence. This will tell you at one point, that means in June 2021, in that particular village, how many are hypertensive. So what is the formula of prevalence? Prevalence formula is, that is a very, very important MCQ. Total cases divided by total population, or you can even say media population into 1000. This is the formula. So per 1000 people in an area, how many are having a particular disease? Okay, this is prevalence. Very, very important. Formula for prevalence. Here also formula, the name of the indicators are important. Formula is important and application part for solving problems. That is also very important. Okay, next let's see what is incidence. Incidence is number of new cases developing over a period of time. Okay, number of new cases developing over a period of time. Now let's see how to find it out. Let's say, take the same example. I want to find out the number of new cases of hypertension in age group more than 50 years in, say, village X developing between June 1st, 2021 to, say, December 31st, 2021. Okay. I want to know the number of new cases which are developing over this period. So how can I do that? First, I'll go to that village X and I'll start my study in June 1st. And I'll see how many are there in that population which are more than 50 years. Now what is next? I only want the number of new cases which are going to develop in that age group, right? So I don't want those who are already hypertensive, because I want only the new people who are developing the disease, right? So what I'll do is, I'll just take out those who are already hypertensive from that, and then I'll follow up those above 50 years who do not have hypertension till December 31st to see how many new cases of hypertension are developing in that group. Is it clear? So this is how you find out incidence. So what will be the formula of incidence? Formula is number of new cases divided, number of new cases divided by, what do you have in the denominator? It is not total population, but total population at risk. At risk. This itself is an MCQ. What is the denominator of incidence, or what is the formula of incidence? Now my question is, what do you mean by at risk? See, in prevalence, it was total cases divided by total population, whereas in incidence, it is total population at risk. This means, in this denominator, you don't include those who already have that outcome that you're studying. Okay. So here, not disease. Disease means a disease that you are trying to find out in future. Okay. And each and every person is equally susceptible to develop the disease. Okay. Susceptible to develop the disease. What do you mean by this? This means, listen, suppose I want to find out the incidence of measles. Can I include those children who are immunized for measles in the denominator? No, because they are not at risk to develop the disease. Can I include those children who already got measles in the denominator? Again, no. Right? Suppose I want to know the incidence of CA endometrium. Can I include males in the denominator? No, because they are not at risk to develop the disease. Can I include those females who had already undergone hysterectomy? Again, the answer is no. I hope the message is clear. This is what you mean by at-risk population. See, this concept is very, very important, because for your exam, you will be given a lot of numbers. Okay. And you should only correctly pick those who are relevant for your denominator, only those who are susceptible to develop the disease. Hope I'm clear. Okay. This understanding is very important as far as incidence is concerned. So, the formula of incidence is number of new cases divided by total population at risk into 1000. Okay. Whereas for, okay, let me write into 1000 as well. Into 1000 or into 10,000. Anything you can write. Okay. It only means per 1000 who are at risk. Whereas for prevalence, it is total cases divided by total population into 1000. So both these are very important. Okay. Next MCQ. Again from morbidity. Prevalence you get from which study design? Survey is an example for cross-sectional study. Okay. So cross-sectional study and survey you can equate all the time. You're taking a cross-section. That means you're taking a survey. Whereas incidence you get from which study design? Here what are you doing? You are following them into future. So it is cohort study or prospective study. Both are MCQs. Prospective or cohort study design. SD study design. Okay. Again, very, very, very important MCQ. Okay. Moving on to the next MCQ. P equals I into D. That is also an MCQ. P equal to I into D. By the way, what is P? Prevalence. What is I? Incidence. What is D? It is duration. That means as duration increases, prevalence goes on increasing, right? Think. That's how it works. Okay. Next, I'm going to show you a picture which includes 4 more MCQs. Okay. Look at this picture. What do you see here? As incidence increases, prevalence increases, right? As recurrence increases, prevalence again increases. As mortality increases, prevalence decreases. As cure rate increases, again prevalence decreases. So this has 4 MCQs. Hope you're with me. Okay. So we have seen all the MCQs from morbidity as well. Now let's see how to solve some problem-based questions. Very simple. Just one question. You'll get something similar to this. In a town of population 5,500 are already myopic on Jan 1, 2019. Number of new myopia cases is 90 till December 31, 2019. Calculate the incidence of myopia in the town 2019. What is the formula? Number of new cases. There is no doubt new cases are already given. It is 90. Okay. So it is 90 divided by, what do you want to put in the denominator? Is it 5,000? 5,000 is total population. Now, you want population at risk. That means 500 are already myopic. They are not going to be new cases. So, 5,000, from that 5,000, you take out 500. So, only 5,000 minus 500 are population at risk. Okay, so what answer will you get there? 90 divided by 4,500, you will get it as 0.02. So, this is how you should think when you're getting a question from this. Okay, moving on to yet another important topic in epidemiology, which is study designs. You can expect questions from study designs. We usually use study designs in research. I'm not going into those details, only the MCQs. We'll start with the first one. First study design, cross-sectional study. You know, we have already discussed what is cross-sectional. Example is a survey, right? So, what is it? First MCQ, it's a one-time examination. One-time examination of a cross-section of a population. One-time examination. And when you do a survey, we have seen, what do you get as the outcome? Prevalence. You get prevalence from a cross-sectional study design. Example is survey. All these are, so doing a survey is an example for cross-section study. These are the MCQs from cross-section. Second, we are going to see case control and cohort. Next is case control study design and cohort. Let's see few MCQs which are common to both these. First, both are analytical study designs. Both are analytical study designs. I'm going to write it as ST. What do you mean by analytical study design? Analytical means there is an exposure. In both these, there is an exposure and an outcome. Okay, for example, smoking and lung cancer, the most commonly dealt, smoking and CA lung. Smoking and lung cancer, most commonly seen example when you are studying case control and cohort. Okay, so in both there is an exposure and outcome, and you want to know whether this exposure and outcome are associated or not. Okay, or is there any relationship between this exposure and outcome? Then what is the difference? The difference between case control and cohort is that the direction in which you do the study is different. In case control, you are starting the study and then you are going backwards. We'll see how you do it. Whereas in cohort, once you start the study, you are going forward. Okay. So this is a basic difference. One is backward and the other is forward. Whereas both are analytical, and in both you are comparing exposure and outcome. Now, let's see. Case control first. Okay. So this is a case control study design to know the relationship between CA lung and smoking. Now, what is case control? In case control, as the name indicates, you are starting the study with cases and controls. By the way, who are cases? Those with disease. Controls are a group without that particular disease. Okay, and you are retrospectively assessing their exposure, whether they have that exposure or whether they had that exposure in the past. Now, what you see here is the case control study design. Okay, this itself is an MCQ. This design itself, okay, you can get it as an image-based question. Okay, so how do you do this? Suppose I want to know the relationship between CA lung and smoking using case control. First, this is where you are starting the study. Okay, this is where I start the study. Okay, so I have, first I'll start with cases and controls, right? So I took 100 CA lung patients as cases and 100 normal people, that means without CA lung, as controls. Then I asked each and every person in my case about their history of smoking. Okay, I asked them, do you smoke or have you ever smoked? And same question I asked to each and every person in my control. And then I found out the number of smokers among my cases and number of smokers among my controls. And this difference is what you are comparing. This difference in the exposure rate is what you are comparing in a case control study. Are you with me? That's it. Okay. So here this is the start, and this is where you are ending the study. Okay. Whereas in cohort, by the way, what do you mean by cohort? I said case control is known as case control because you're studying cases and controls. Cohort is known as cohort because you are studying a cohort. A cohort means a group with common exposure. Common something is what you call as cohort. So this is a group with common exposure. So naturally, you are starting with a group of exposed and non-exposed. Here, in this particular example, see, this is where I am starting the study. This is a start. So you're taking a cohort of exposed and non-exposed. Here I have 100 smokers and I took 100 non-smokers. Make sure that when you start the study, nobody has got the outcome. That means no one is having CA lung. Then you follow them into future for say 10 years or 20 years, and at the end of your study period, you see number of CA lung cases that developed among your smokers or exposed, and the number of CA lung cases that developed among your non-exposed, and this difference in the outcome, rate of outcome in these two groups is what you compare in a cohort study. Okay, so look at this. This is the basic difference. Can you see? So this is where you start. See, start. Here you're starting in case control, you're starting and you're going backwards. So this is known as retrospective study design. Which one is retrospective? That is the next MCQ. Retrospective is case control. Whereas in cohort, it is a prospective study design because you are starting from here and you are ending in future. This is the end. This is where you end. Are you with me? Okay. Now, let's see what are the outcomes in each of this. We are not going into details, only the MCQs. Okay. The outcome that you study in a case control is odds ratio. Outcome is odds ratio in case control. Okay. And next MCQ, odds ratio will give you the strength of association. So strength of association in a case control is given by odds ratio. Suppose you are getting odds ratio as 6. That means smokers have 6 times more chance for developing lung cancer compared to non-smokers. Is it clear? Okay. Odds ratio equal to, or I'll start with odds ratio more than 1 means this exposure is a risk factor. Okay, odds ratio less than 1 means this exposure is a protective factor. And odds ratio equal to 1 means there is no association. Are you with me? This is protective factor. This is risk factor. So odds ratio more than 1 means this particular exposure is a risk factor, whichever be the exposure. Equal to 1 means there is no relationship between this exposure and outcome. Less than 1 means this particular exposure is a protective factor, as in the case of vaccination and the disease. Are you with me? Moving on to what are the outcomes in a cohort study. This is cohort. What are the outcomes in a cohort study? Unlike in case control, cohort has 4 outcomes. The names are important. We'll see the names. First one is incidence. We have already seen what an incidence is, right? Second is relative risk. Third is attributable risk. And the fourth is population attributable risk. Attributable risk. I'm going to write it as AR, population attributable risk. So these are the 4 outcomes in a cohort study. Next MCQ. And the last MCQ from this, or a very important MCQ from this is, among these 4, which one will give you the strength of association? See, in case control, odds ratio will give you strength of association, right? Whereas in cohort, very, very important question. Which among these 4 will give you strength of association? It is relative risk will give you strength of association. And the interpretation is just like what you do in odds ratio. If relative risk is more than 1, that means it's a risk factor. Less than 1, it is a protective factor. Equal to 1, that means there is no association. Okay. So we have seen all the important MCQs from case control and cohort. Okay. Moving on to the third study design, which is RCT. Made the picture. This is how an RCT looks like. Okay. Randomized control trial or RCT. These are mainly drug trials. Okay, so you will be dealing with patients. So what you do here is, this is where you start the study. Okay, you take a group of patients. Here I'm going to see a new antihypertensive. Okay, so you have 100 hypertensive patients. You divide them into two arms. One is now of almost equal number. One arm is known as the treatment arm, the other is known as control arm, and this division is known as randomization. You are randomizing them. This is known as randomization. Okay, you are randomizing them into treatment arm and control arm. Okay, of almost equal number. So you have 50-50. To the treatment arm, you are giving the new drug or some drug that you are evaluating, and to the control arm, you give placebo. Okay, and you are following them in the future to see what percentage got cured because of your new drug and what percentage got cured because of your placebo, and this difference in the rate of outcome among the treatment arm and control arm is what you compare in a RCT. Are you with me? So this is the design of an RCT, which is again an image-based question. Okay, now let's see what are the outcomes in an RCT. Only the names, outcome measures in an RCT. First one, intention to treat analysis. Just be familiar with these names. Intention to treat analysis, which is a frequently asked question. Second outcome is efficacy of a drug. Efficacy of a drug. And the third is number needed to treat. Don't worry what it is. Okay, number needed to treat. If I had time, I would have definitely discussed what it is. Okay, this is also known as NNT. Okay, NNT, number needed to treat. So these are the outcomes. So we have seen what a case control is, just to go through. So this is the design of case control, and the outcome is only one and only odds ratio, which will give you the strength of association. A prospective study is cohort, where you have 4 outcome measures and strength of association is given by relative risk. And this is randomization, which is an experimental study design. Okay, let me write that as well. It's an experimental study design. It's an experimental study design or interventional study design. And the outcome are 3 in number. So we have 1, 4 and 3. Intention to treat analysis, efficacy of drug and number needed to treat. Okay, I hope you are with me till here. So cross section over, case control over, cohort over and RCT over. Okay, don't you want to see how the questions from study designs will look like? Just 2 questions. Okay, 2 prototypes. Residents of 3 villages with 3 different types of water supply were asked to participate in a survey to identify cholera carriers. Because several cholera deaths had occurred in the recent past, virtually everyone present at the time submitted to examination. The proportion of residents in each village who were carriers were computed and compared. Classify the study design. What is it? See, when there is a disease outbreak, they have done survey in 3 nearby villages to find out the percentage of cholera carriers. So what is it? It is cross-sectional study. Okay. In a study which began in 1965, a group of 3,000 adults in Baltimore were asked about the alcohol consumption. The occurrence of cancer was studied in this group between 1981 and 1995. So what is it? They're starting the study in 1965 with a group of alcoholics, and they are following them into future to see the number of cancer cases. So what is it? This is cohort. Okay, this is a cohort study design. So this is how the questions will appear. Next topic of discussion from epidemiology is levels of prevention. Before going into levels of prevention, first MCQ is, what do you mean by natural history of a disease? Natural history of a disease, that itself is an MCQ. It is a phenomenon by which a disease evolves over time from its initial stage to the final stage in the absence of external intervention. That means if you don't do anything from outside, how a disease develops from its first stage till the last stage. Okay, this is natural history of a disease. Are you with me? Now let's see how a natural history of a disease usually is. Okay, see, First, you have a very healthy community, right? Free of any risk factors. What is the first thing that is happening? Some risk factors will evolve, right? And the man will come in contact with the risk factors. So first risk factors are evolving and man is in contact with the risk factors. That means you are in the midst of risk factors. And you know, mere presence of risk factors will not give you disease, right? You need some time for the disease to develop. Okay, that means you are already surrounded by a lot of risk factors, but no disease yet, luckily. What do you call that period as? That is pre-pathogenesis phase. Okay, after some time, what happens? The disease will start developing. So this is disease. And once disease develop, you are going into which phase? Pathogenesis phase. You are going into pathogenesis. This was pre. This is pathogenesis phase. Then after that, what happens? The pathogenesis will progress, and the final outcome will happen. Sometimes in the form of complications, sometimes in the form of death. It depends upon which the disease that you're dealing with. Okay. So look at this. This is the whole natural history of a disease. Okay. If you don't intervene from outside, that is natural. Okay. Are you with me? Now, depending upon where exactly you intervene from outside, we have 4 levels of prevention. Okay. Which are primordial, primary, secondary, tertiary. Okay. Now, what is primordial prevention? Primordial means you are intervening at the very first stage here, where you are preventing the emergence of risk factors in a community which doesn't have it. Okay. So that is primordial prevention, where you are removing the probability that risk factors will ever evolve. No risk factors at all. Suppose you failed here, what will happen? Risk factors will come up and you are surrounded by a lot of risk factors, but no disease yet. That means in pre-pathogenesis phase. If you are intervening at this stage where risk factors are there, but you are removing the possibility that the disease will ever occur, it is known as primary prevention. This is primary prevention. Okay, these are various levels of prevention. Levels of prevention. Suppose you failed here as well. What will happen? Then naturally the disease will come up. Okay, now we are left with just 2 more levels of prevention, which are secondary and tertiary. Now my question is, if both secondary and tertiary are done after the disease develop or pathogenesis phase, what is the difference? What is the difference then? You know, the pathogenesis phase is again divided into 2. You have early pathogenesis phase and late pathogenesis phase. What do you mean by early pathogenesis phase? As the name indicates, pathogenesis has just started. That means the person is still in the reversible phase. He is still in the reversible phase. If you can intervene at this stage, you call it as secondary prevention. Okay, if you are intervening here, you call it as secondary level of prevention, and you can bring the person back to a normal life. Now, what is tertiary? You are intervening in the late pathogenesis phase. Late means, as the name indicates, it's already late. That means the patient has already gone to the irreversible phase. Whatever you do, however you try, you will not be able to give a normal life to the patient. What you can do is, you can prevent further disability and maybe you will be able to rehabilitate. Okay, so when you intervene in the late pathogenesis phase, you call it as tertiary. Tertiary level of prevention. Are you with me? So these are the 4 levels of prevention. Okay. Now, next MCQ is, what are the modes of intervention? Very important. That means, what are the activities that you can undertake under each of these levels of prevention? Let's start with the first one, primordial. Suppose I want to do a primordial prevention for preventing the risk factors of lifestyle diseases. How can I do that? Can I do it among you guys? Of course not, because yours is a population which has got a lot of risk factors. So I want a population which is free of these risk factors at least till today. So where can I get them? I have to go to schools, or I may have to go to kindergarten. Okay. And I have to teach children, their parents, their teachers, so that they will never ever adopt any unhealthy lifestyle. Okay. So what you do under primordial is mainly health education. Okay. And what I can do among you guys is primary prevention. I told you, yours is a population which has got a lot of risk factors, but luckily no disease yet. So I can somehow try to prevent the emergence of disease even though you have a lot of risk factors. So what are the modes of intervention that I can do there? There you can do two modes of intervention, which are health promotion and specific protection. Very important. Okay. Now what do you mean by health promotion? Health promotion means I'm just trying to improve your health or simply promoting your general well-being by asking you to take good food, asking you to do regular exercise so that you can fight against almost, or you can prevent almost all lifestyle diseases. Whereas specific protection means, as the name indicates, you're trying to specifically protect one disease alone. For example, giving vaccination. It is an example for specific protection. Giving vitamin A prophylaxis. That is an example for specific protection. Okay. So under primary, you can do two interventions. One is health promotion and the third is specific protection. Now, what is secondary? Secondary, I told you, you are doing it in the early pathogenesis phase. You are trying to detect the disease at the earliest and start treatment. So, what are the interventions? There you can do early diagnosis, screening and starting treatment are the modes of intervention that you do under secondary. And what is tertiary? We have already discussed. In tertiary, you are trying to rehabilitate the patient and you are trying to prevent further disability. So, the modes of interventions are disability limitation and rehabilitation. Please keep this in your mind. There is no need to mug up. Okay, modes of intervention are very, very important MCQs. And these definitions of levels of prevention are also important. Okay, a question which is commonly asked from levels. Screening is the most commonly used epidemiological tool in school health services. Which level of prevention does it refer? Screening is secondary, right? Course of disease, process without any intervention. Without any intervention is natural. History of a disease. Which of the following is not a primary prevention? Pulse polio immunization, it's a primary prevention. Vitamin A supplementation, it's a primary prevention. Self-breast examination for tumor is screening, right? That is coming under secondary. INS again, primary. So, this is the answer. Self-breast examination. So, these are the types of questions that you can expect from the levels of prevention topic. Okay? So, we are done with general epidemiology, where we have studied mortality indicators, morbidity indicators, various study designs and levels of prevention and certain MCQs from that. Next, let's see a very important topic in statistics. A commonly asked topic in statistics. By the way, what I'm going to tell you is not statistics but biostatistics. Biostatistics or medical statistics, where you are actually dealing with patients. And what are you actually measuring in patients? You are measuring their variables. Okay, you're studying various variables among patients. Okay, so that brings you to the next question. What do you mean by variable? Variable means an attribute which vary from one person to another. For example, what are the examples for variables? Height. It varies from one person to another, right? Weight, age, blood pressure, cholesterol level. All these are various variables, and among patients, these are the things that you are studying, right? So, there comes the importance of typing of variables. So, we have various types of variables, which is very, very important for your exam. Okay, so that's what you are going to learn under statistics. Types of variables. Types of variables. You know, variables are mainly divided into two. One, qualitative variable, also known as categorical variable, and the second is quantitative variable. Now, what do you mean by qualitative variable? Qualitative means, as the name indicates, it denotes the quality of a variable. Quantitative means, as the name indicates, something which is quantifiable, or the answer will be always in terms of numbers. Okay. Now, qualitative is again divided into three, which are, that is very important. Qualitative is again divided into three, which are nominal. Okay, let me write 1, 2, 3. 1, nominal. 2, ordinal. 3 is binomial. Also known as dichotomous variable. Okay. Now let's see what is nominal. Nothing to mark up. Very, very simple. Okay. Nominal. What do you mean by nom? Name. So as the name indicates, this denotes the name of a variable. For example, gender. Male is name of a gender, female is name of another gender, right? Blood group. A, AB, O, all these are names of various blood groups. Hair color, white, black, burgundy, all these are various names of hair color. So such variables which have got a name you call as nominal. Okay. Second is ordinal. Nothing to mug up. As the name indicates, ordinal means there is an order. For example, pain. Pain scale, mild, moderate, severe. There is an order, right? This mild is less than moderate, less than severe. Pain scale. Then TNM classification. Stage 1, stage 2, stage 3. There is an order. Stage 1 less than stage 2, less than stage 3, less than stage 4. Apgar score. Then Glasgow Coma Scale, GCS. All these are examples for ordinal variable. Are you with me? Next is binomial or dichotomous. As the name indicates, what do you mean by bi or di? 2. That means only 2 outcomes are possible. Example, is a patient dead or alive? Alive or dead? It's a binomial. Only these 2 are possible. You can't have anything in between, right? Second, number of passes and failures. Passes, failures. So such variables where only 2 outcomes are possible, you call it as binomial or dichotomous. Hope you're with me. So that's all about categorical or qualitative. Now moving on to quantitative, there are 2 subdivisions for quantitative. It's easy. One is continuous. Continuous variable, and the second is discrete variable. Now what do you mean by continuous? As the name indicates, continuous means you can have a continuum of values. That means decimals are possible. The easiest way to remember is decimals are possible. Decimals are possible. As in the case of height. Decimals are possible, right? 177.1, 177.2, 177.3. So any number of decimals are possible. Weight, again, any number of decimals are possible if you are having a very sensitive machine, right? So these are examples for continuous. Now what is discrete? Discrete means whole numbers. Only whole numbers are possible. Only whole numbers are possible. As in the case of number of children, number of states in a country, all these are coming under discrete variable. Is that clear? So this is how you classify variables. Okay. Now let's see how the questions will appear. All the following are quantitative variables except serum cholesterol. It's a continuous variable, right? Weight, continuous variable. What about gender? It is qualitative nominal variable. Don't say binomial or dichotomous. It's not binomial anymore. You know that, right? We have 3 options now. Celsius scale, again, quantitative. So the answer is gender. Which of the following variable is an example for nominal scale? Again, height, quantitative, continuous. Ethnic group, that is nominal. Social class, ordinal. Age categorized as young, middle, old, again, ordinal. Age in years, by the way, is age continuous or discrete? This was also a question. What do you think? Of course, it is quantitative. Continuous or discrete? It is continuous. Okay. It is continuous, not discrete. How do you depict the age of children? In days, infants. Age, months, right? You're right. Your age is 22 years plus this many months plus this many days. So any number of decimals are possible. Okay. Months, days. Anything is possible. So decimals are possible and age is a continuous variable. So here the answer is ethnic group. Hope you're with me. Next topic we are going to discuss is sampling techniques. Sampling techniques. Now what is it? Suppose I want to do a study on hypertension or diabetes. I will not be taking all patients with hypertension or diabetes for my study, right? I'll be just taking a small sample and I'll be studying them alone because that is the only feasible way of doing any study. Right? And even otherwise, we doctors know that taking sample alone is sufficient because we are already in the habit of taking samples. Blood sample, urine sample, FNAC, all these are methods of taking sample, right? And in research as well, you are taking a sample alone from the population and study. And that is sufficient provided your sample is a true representative of your population. What do you mean by that? Your sample must be a true representative of the population. That means if your sample has all the characteristics which are there in the population, then you need to study the sample alone. Now my question is, how can you ensure that your sample is a true representative? For that, there is a scientific technique by which you have to draw or you have to take sample from the population, and that method is known as sampling method or sampling technique. Okay, now let's see how sampling techniques are divided. Sampling techniques are mainly divided into two. One is random sampling and the second has to be, first is random, so second has to be non-random sampling. Okay, first MCQ from this. Of course, these two are MCQs, and the next MCQ from this slide is, which among this is the best? Random sampling is the best. If possible or whenever possible, go for random sampling. Okay, next, random sampling is again divided mainly into four. One is simple random sample. Okay, before that, let me tell you the type of questions that you can expect. These names are important and there are certain features for each of this which are also important. And you will be given a situation and you will have to, that is a third type. You have a situation will be given and you have to say whether it is coming under simple random or stratified random, like that. Okay, so let's see the questions first. The list of random sampling techniques. Four. First one, simple random. Second is systematic random sample. Third is stratified random sampling. And the fourth is multi-stage random sampling. Now let's see the MCQs from within each of these. What is simple random sampling? As the name indicates, simple random sampling is not a simple random sampling because this is simplest method of taking sample from the population. Now, which is simplest method? Suppose I want a sample of 1 from 100 students in a class. Which is simplest method that is coming to your mind? That has to be simple random sampling. Taking out lots, right? Yes. So, taking out lot is an example for simple random sampling, and that method is known as lottery method. So, example for simple random sampling is lottery method. Second MCQ from this. This will ensure equal and non-chance for each and every person, right? Suppose, as I told you, out of 100, I want 1 person. What is the chance that, when I take a lot, what is the chance that each person will be included into my sample? It will be 1 by 100, right? That means I know that I have a 1 by 100 chance of getting included in the sample. It is non and it is equal for everyone. Hope you are with me. So these are the MCQs from simple random sampling. Next is systematic random sampling. As the name indicates, systematic random sampling is known as systematic random sampling because you are taking sample in a systematic pattern. For example, suppose I want a sample of 5 from 100 students in the class using systematic random sampling. Then I may say, okay, every 7th person will be included into my sample, or every 10th person will be included into my sample. Then I'll start counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. The first 10th person will be my first person in the sample. Then I'll again do the same. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Then next 10th person will be included. I'll go on doing this till I get 10 from the population. Is it clear? So here the MCQ is every nth person in systematic, every nth person is selected into the sample. And this is how you do systematic random sampling. Say every 3rd person in this particular example. Okay. Next is stratified random sample. As the name indicates, stratified random sampling is known as stratified random sampling because you are stratifying the population before taking the sample. By the way, what do you mean by strata? Strata means levels or groups, right? You are making them into homogeneous groups or different levels. Okay, for example, there is a class having boys and girls and I want a sample of 5 boys and 5 girls using stratified random sampling. What I'll do first is, I'll divide this heterogeneous population into 2 strata. A strata of boys, a strata of girls. Then I'll randomly pick 5 girls from girls strata and 5 boys from boys strata. Okay, so this is stratified random sampling. First, you are stratifying them into various groups like this. Look at this picture. Then you are taking equal number randomly from each strata. Okay, so that is an example for stratified random sampling. So this is also an example for stratified random sampling where you are stratifying the population into various groups. And the fourth one is multi-stage random sampling. As the name indicates, this is not as multi-stage because this is done in multiple stages or more than one stages. This is usually done at national or international level. Let's see one example, which I always take in class. See, suppose Government of India wants to do a study on nutritional status of school children. That means at the national level, they want to find out the nutrition status of school children all over India. Here they can make use of multi-stage random sampling. Now, let's see how to do it. In the first stage, they'll write down the names of various states in India. Then they'll randomly pick a few states. In the second stage, they'll write down the names of various districts in these selected states. Then they'll randomly pick a few districts. In the third stage, they will write down the names of various schools in these selected districts and they'll randomly pick a few schools. So their final end product will contain random representation of school children from various parts of India, right? So this is multi-stage random sampling done like this. See, you can start from country, then coming to state, then coming to below that. Again, you can go up to any minute level starting from a hi-fi setup. Is that clear? So this is multi-stage random sampling. Okay, here the another MCQ is, see this picture is an MCQ. Successive sampling unit is from the previous sampling unit. Successive sampling unit is from previous sampling unit. That means third will be from second, fourth will be from third, like that. Successive is from the previous sampling unit. So this covers various types of random sampling methods. Okay, moving on to non-random sampling. Non-random sampling methods. Non-random sampling methods are mainly divided into two. One is convenience sampling and the second is snowball sampling. Snowball sampling. Now, what is convenience sampling? As the name indicates, you are taking sample as per the convenience of the researcher. Okay, here the MCQ is, there is a bias. What is it? Selection bias. That means when you simply take whoever you feel like, your sample will not be a representative of the population. That is a bias. Okay, your sample will not represent population. Then what is the use of studying it, right? I told you it should be a representative. Second is snowball sampling. Okay, now what is this? First MCQ from snowball sampling. It is done to study hidden population. Hidden population. Hidden means difficult to access population. If you want to study difficult to access population, you can do a snowball sampling. Let's take one example. Suppose I want to study the prevalence of STD among commercial sex workers. They are a hidden population, very difficult to access. Here I can make use of snowball sampling. Okay, now listen carefully. You will understand how to do snowball sampling. What I'll do first is, I'll somehow catch hold of one CSW, collect data from her. Okay, now she will be knowing, this is my first CSW. Now she will be knowing 1 or 2 or 3 others who are indulged in the same profession. So through her, I can reach them and collect data from them as well. Now they may in turn recruit 2 or 3 more. Okay, so like that, I can go on increasing the size of my sample till I get sufficient sample for my study. Are you with me? Okay, now why this is known as snowball sampling? As the name indicates, This is known as snowball sampling because it is showing the property of a snowball. By the way, what is the property of snowball? When it starts from the top of the mountain, it will be a small tiny ball, right? But as it rolls down the mountain, it will collect more and more snow, and by the time it reaches the bottom, it will be a huge big ball, right? That property we are making use to study hidden population like this. Okay, so this is an example for snowball sampling. So these are the various types of sampling which I think you have understood. Okay guys, so we have come to the end of our review session. We have discussed all important topics in community medicine. I hope that helped you to revise. All the best for your exam. My wishes and prayers. If you have any doubt, you can always contact me. I'll be available. Take care. Stay safe.